Thank you, Kumar sir, for this opportunity to speak in this IC about endophthalmitis. Like we said before, can we have the slides? Like we said before, there is going to be a lot of overlap. So nowadays it's very fashionable to say, don't not do this or don't not do that. So that becomes a do only. So either way, it is okay to have overlap and reiterate the same things because you can never overemphasize anything when it comes to endophthalmitis. So don'ts can be divided into don'ts that help in prevention, don'ts that help in diagnosis, and don'ts when it comes to management. So these points also Kumar sir was kind enough to share with me and add to my presentation. So don'ts that help in prevention. We should not be lackadaisical in some situations. And these are when the patient has high risk of endophthalmitis. High risk patient means high risk eyes. So, who are the high risk patients? Diabetics, especially those with a higher HbA1c, or those who have had an acute control of HbA1c when the HbA1c levels have been drastically reduced. Those patients on dialysis for chronic kidney disease due to diabetes or any other cause, and diabetic foot is a source potentially of systemic sepsis, septicemia. In patients with malignancy and those with chemotherapy, their colonic infections are very common, and microemboli of microorganisms into the bloodstream are very common. So these patients have a subacute sepsis, and it is safe to assume that they are always in a state of subacute sepsis because of this. So in such patients, a blood culture, urine and stool culture is probably indicated more often than not, because that can uncover some infections, and we have to be on guard for such patients. Even patients on chronic steroid therapy or immunosuppressants for collagen vascular disease or any other immune mediated diseases are high risk patients. And many times in the community or camps, we operate on patients who are homeless or destitute and have very very poor hygiene. Such patients are also high risk. Next, we should not neglect post-op instructions, as very nicely pointed out by Dr. Kumar. Now, when we prescribe patients with post-op medication, we usually say that topical steroids have to be used in a tapering manner, and initially it can be as high as hourly or 2 hourly. And the cycloplegic is what we instill twice a day or maybe even once a day. But when the patient comes for a follow up, to our utter shock and surprise and dismay, the patient is actually putting the cycloplegic once every hour and the steroid twice a day. So in such cases, we slap our head, and that's probably because of a miscommunication on part of us, or when we delegate such instructions to the fellow or the resident, and who in turn gives these instructions to the patient. So maybe uh, we have to make sure that there is no miscommunication, and the detailed and comprehensive prescription has to be given. it we have seen that it helps when we write the instructions or the dosage on the packaging of the drops. Coming to don'ts and diagnosis. So in the camp and outreach community programs, we do use a flashlight for screening patients who have to undergo surgery pre-operatively. Unfortunately, because of the hundreds of patients, we sometimes tend to use a flashlight or torch for post-operative examination. Here I have used this photograph just to show that there is a very early hypopion here, and it can be missed on torch examination or a flashlight examination, especially if there is an inferior bleb or a conjunctival bleb when we have injected a subconjunctival antibiotic and steroid combination. It can obscure the hypopion. So when there is a chemosis on post-op day, it is always preferable to look underneath it for a hypopion. And slit lamp is the way to go. It has to be used always and always for every patient we have operated. Next is, don't hope against hope that it is not endophthalmitis and delay action. We have to keep the patient admitted and monitor every few hours and can discharge after 24 hours. So, if we tell the patient that there is a reaction that was unexpected post surgery, the patient also becomes a little alert. Of course, there's a way of communicating things. Infection, the word infection can alarm a patient. So instead of that, if we say something like there is some unexpected reaction and you would like to observe, the patient will be inclined to stay back and you can discharge them after 24 hours. So hoping against hope that it is TAS is not a good idea. We have seen the differences between TAS and infective endophthalmitis in many presentations, but like I said, to reiterate, TAS is usually on the first post-op day and there is no pain. Lid edema is uncommon, congestion is minimal, corneal edema is limbus to limbus, the iris is fixed and the pupil is fixed and dilated, the IOP can be raised, and the response to topical steroids is dramatic. Infective on the other hand is a little delayed, maybe third postoperative day to seventh, depending on acute or subacute onset of the endophthalmitis and the virulence and inoculum of the organisms. Pain may be present, but what is most important is the diminution of vision. Congestion can be more than that seen in TAS. Corneal edema is patchy. Pupil can be variable in size. IOP is also variable, and the response to steroids is only temporary. Coming to don'ts in treatment, we should not delay injection just because we don't have access to gram stain culture and sensitivity. We don't delay in giving an intravitreal empirically with amikacin and moxifloxacin, and this has been the antibiogram susceptibility that is seen in this part of the world. And even if tap and cultures are not possible, it is always better to give an intravitreal empirically, because if we do get a microbial diagnosis and we see that this eye or this infection is susceptible to what we are already giving and the patient is doing well, that is the end of treatment. Suppose in the microbial diagnosis the susceptibility is not there. In fact, it shows the resistance to the antibiotics that we are using, but the patient even then is doing well. We don't recommend switching off the antibiotics to the ones that the organism is susceptible to. So a clinically eye doing well, continuing the use of what is working is recommended, and that will in fact be the end of treatment despite non susceptibility on the antibiogram. So another very important don't is to not overtreat with analgesics. So when a patient requires NSAIDs or any other pain medication for more than a day in a surgery like phacoemulsification, which should not be painful, uh, that means all is not well. So pain can be masked with overuse of NSAIDs, and that can be a false reassurance that pain is not there. It can be a false lull that the patient can be in, because it doesn't alarm the patient to come back to the treating physician. Of course, we should not ignore the dose or the method of preparation, like Kumar sir showed. He said a very nice sentence that the faintest ink is better than the brightest memory. So we keep a chart of antibiotics and their preparation methods on the wall of our OR, of all our ORs if there are more than one. And we know how to make these intravitreal preparations. Also, there is something called an e-kit that you can keep, which has all the requirements for treatment or giving intravitreals: the antibiotics, the diluting solutions, the appropriate number of syringes for dilution, the injecting syringes, a speculum even, and the needles. So last point is to not delay referral for sure. If there is no response in 12 to 24 hours and the patients seem to be worsening with increase in hypopyon, congestion, further drop of vision, especially less than 1 by 60, if the glow disappears, if there are vitreous echoes on ultrasound, we refer immediately, because in endophthalmitis, like everybody before me has said, timing of definitive treatment, that is vitrectomy, is crucial. Thank you.